Chronic stable angina. Angina is the most common manifestation of ischemic heart disease. It is a syndrome characterized by chest discomfort associated with myocardial ischemia without necrosis. It is defined as stable if it has not changed in frequency, duration, or precipitating cause in the past 60 days. Angina results from an imbalance between the zygon supply and demand of the myocardium, hence the relationship of chest pain with exercise. By far the most common cause is ischemia resulting from atherosclerotic narrowing of the coronary arteries. Hemodynamic compromise usually occurs after a 70% reduction in the luminal diameter of a coronary artery. Reduction of flow may also occur from coronary artery vasospasm. Angina can also result from reduced oxygen carrying capacity of blood, anemia, and increased oxygen demand. Can be due to myocardial hypertrophy, for example, valvular heart disease. The acute complications of angina tend to result from atherosclerotic plaque instability, ulceration, and fissuring of the plaque may lead to acute coronary syndromes. Presenting as unstable angina P25 or non-ST elevation, myocardial infarction, NST-MI P25. Embolus or thrombosis may result in coronary artery occlusion and ST segment elevation. Myocardial infarction, STMI. Myocardial ischemia also predisposes to arrhythmia and sudden death. The history is crucial to the diagnosis of angina. It is exemplified by the character, location, and duration of chest pain. The most consistent feature in the history is the relationship of chest pain with exercise. Classic angina is characterized by tight chest discomfort that originates in the precordium and radiates into the jaw, shoulder, or left arm. Occasionally, it may be described as pressure, an ache, weight, or constriction, but rarely as a sharp or stabbing pain. Typically, angina is precipitated by exertion and relieved with rest. Each episode usually lasts from 1 to 3 minutes if the initiating event is discontinued. Other precipitating factors may include emotion, meals, cold weather, and lying supine. Decubitus angina. Variants of angina include vasospastic or Prinzmetal's angina that occurs without provocation due to coronary artery vasospasm. It is diagnosed by characteristic ECG changes of ischemia associated with the attacks of chest pain. P3. Classical angina with objective evidence of myocardial ischemia can manifest with apparently normal coronary arteries on angiography due to microvascular disease, syndrome X. Occasionally, the only manifestation of cardiac ischemia may be dyspnea, angina. Equivalence. A detailed history should identify risk factors associated with ischemic heart disease and underlying factors predisposing to angina, anemia, thyrotoxicosis, infections, drugs, and discriminate between other causes of chest pain. The severity of chronic stable angina is graded according to the Canadian Cardiovascular Society classification. Clinical examination is often normal. However, evidence of risk factors or concomitant manifestations of atherosclerosis may be evident on careful examination. A corneal arcus and xanthelasma is associated with hyperlipidemia. The blood pressure may be chronically elevated. Auscultation of the carotid arteries may reveal concomitant carotid stenosis. An ejection systolic murmur may suggest aortic stenosis as the underlying cause, while a pansystolic murmur may reflect mitral regurgitation that can result from ischemia. Peripheral pulses should also be examined for concomitant peripheral vascular disease, known to be strongly associated with coronary artery disease. Full blood count. Anemia can precipitate or exacerbate angina. Plasma glucose. A random plasma glucose should be obtained to screen for diabetes. Lipid profile. Serum cholesterol levels have important implications for therapy in primary and secondary prevention of coronary events. The resting ECG in patients with chronic stable angina is normal in more than 50%. This does not exclude the presence of ischemic heart disease. Evidence of Q waves from previous myocardial infarctions strongly supports the diagnosis of angina. The presence of arrhythmias such as atrial fibrillation may result from myocardial ischemia. In the presence of chest pain, however, the ECG is abnormal in more than 50% of patients with angina, with T-wave inversion and ST segment depression being the usual finding. The chest film is often normal in patients with chronic stable angina, and the clinical utility of this routine investigation is not well established. Characteristic X-ray features of heart failure from myocardial ischemia may be present, and cardiomegaly secondary to valvular heart disease may point to the underlying etiology. Echocardiography. Transthoracic echocardiography is not routinely indicated in patients with chronic stable angina. However, it is useful when features of valvular heart disease are present or to assess ventricular function in the presence of symptoms suggestive of congestive cardiac failure. Exercise electrocardiogram. An exercise ECG is useful for the objective documentation of myocardial ischemia and also to assess the functional capacity and prognosis of patients with established coronary disease. Details of this procedure are given. Stress imaging studies. The indications for imaging studies over exercise ECG are usually due to baseline ECG abnormalities such as complete left bundle branch block, pre-excitation, Wolff, Parkinson, White, and patients with pre-existing revascularization, where localization of the area of ischemia is important. Details of pharmacological stress testing with radionuclide invasive testing. Coronary angiography. The coronary angiogram is the current gold standard to diagnose coronary artery disease. Currently, it is indicated for diagnosis in patients with contraindications to stress testing, risk stratification in patients with angina refractory to medical therapy, diagnosis after successful resuscitation for sudden near cardiac death, patients with symptoms of congestive cardiac failure, and high-risk patients identified. On non-invasive testing, there are four main aims in the management of patients with coronary artery disease to address underlying conditions that provoke or exacerbate angina, to prevent myocardial infarction and death, to give pharmacological therapy for angina, revascularization, identify and address any precipitating factors. Attention should be given to underlying conditions that provoke or exacerbate angina. These include anemia, hyperthyroidism, tachyarrhythmias, and valvular heart disease. Drugs that are known to provoke angina such as vasoconstrictors and vasodilators should be substituted with other similar agents that have a neutral cardiovascular profile. Lifestyle and risk factor modification. 3. The cessation of smoking should be encouraged as coronary heart disease risk will decline. However, it may be up to 10 years before the baseline risk is achieved. Compared to non-smokers, there is a strong relationship between blood pressure and coronary heart disease risk. Hypertension should be controlled, aiming for a systolic pressure of less than 140 millimeters of mercury and diastolic pressure of less than 90 mmHg. A number of primary and secondary prevention trials have shown that cholesterol lowering is associated with a reduced risk of coronary events, and serum levels should be maintained below 5.0 mol/L. Although definitive evidence is not yet available on strict glycemic control and reduction of coronary disease risk, current consensus opinion favors tight blood sugar control in diabetics and patients with impaired glucose tolerance. Aspirin. The use of aspirin 75 to 325 mg is associated with an average 33% reduction in coronary events for. It should be prescribed for all patients with angina unless absolutely contraindicated. Under these circumstances, an alternative antiplatelet agent, such as clopidogrel, should be considered. Sublingual nitrates. Short-acting sublingual glyceryl trinitrate, a nitroglycerin, works quickly in treating acute attacks of angina. Beta blockers. Numerous beta blockers are available and appear equally effective. The mode of action is by decreasing heart rate, contractility, and blood pressure, and hence the oxygen demands of the heart. Beta blockers are frequently combined with nitrates to ameliorate reflex tachycardia. Although limited data exist in the setting of chronic stable angina, reduction of mortality after myocardial infarction is established. Beta blockers also improve survival and prevent stroke. In patients with hypertension, addition of long-acting nitrates. Prophylaxis can be achieved with longer-acting preparations such as isosorbide mononitrate and isosorbide dinitrates. Nitrates improve exercise tolerance and time to onset of angina by reducing preload and promoting coronary artery vasodilatation. The main problems with nitrates are headaches, which subside as the patient gets used to the drug, reflex tachycardia, and the development of tolerance. There are no long-term studies on the use of nitrates in chronic stable angina. Calcium antagonists exert a negative inotropic effect by reducing the transmembrane flux of calcium. They can be broadly divided into short-acting dihydropyridine, anifedipine, long-acting dihydropyridine, amlodipine, felodipine, and non-dihydropyridine calcium antagonists. For example, diltiazem, verapamil. All the calcium antagonists are of similar efficacy in treating chronic stable angina and are excellent first-line agents for vasospastic Prinzmetals. Angina. Combination therapy with dihydropyridine calcium channel antagonists and beta blockers has been reported to exert a greater anti-anginal effect and better prevent adverse cardiac events than either agent individually. 5. However, non-dihydropyridine calcium channel antagonists act on the cardiac conduction system to reduce the heart rate and should not be used together with beta blockers. In view of the risk of complete heart block, controversy currently exists regarding the prescription of short-acting dihydropyridine calcium antagonists, such as nifedipine, as a single agent for the treatment of angina in view of the suggestion of increased adverse events. The indications for revascularization are symptomatic angina refractory to maximal medical therapy and prognostic Prognostic features for revascularization are determined from a coronary artery disease configuration obtained by coronary angiography. The following adverse prognostic features are clearly associated with survival benefit from revascularization: A. Left main stem coronary artery disease. B. Triple vessel disease. C. Double vessel disease involving the proximal left anterior descending artery. Percutaneous coronary interventions (PCI). Catheter-based intervention techniques are employed for patients with suitable anatomy, discrete and short segments of stenosis without left main involvement, poor ventricular function, or diabetes. Percutaneous transluminal coronary angioplasty (PTCA) is employed by femoral arterial puncture and introduction of a catheter into the aorta and subsequently into the coronary arteries. Balloon dilatation of coronary stenosis is undertaken under radiological guidance. Freedom from angina is achieved in 72% of patients at 1 year. The mortality rate associated with angioplasty is 1%, and the frequency of myocardial infarction is 5%. Other procedural complications are similar to coronary angiography. The main disadvantage is the high proportion of restenosis occurring in 30 to 40% at 6 months has increased due to lower rates of restenosis and reintervention compared to PTCA. Self-expanding stents are deployed in the coronary arteries using the same approach as PTCA. The in-stent restenosis rate is approximately 22% at 7 months coronary artery bypass surgery. The patient is positioned supine and a median sternotomy is performed. The sternum is opened longitudinally with an oscillating saw. The internal mammary artery is harvested Fig. 1.14 simultaneously with the long saphenous vein. By a second operator, the pericardium is opened and cardiopulmonary bypass is instituted. The heart is arrested using cardioplegia solution containing a high concentration of potassium. The segments of long saphenous veins are reversed and anastomosed to the coronary arteries and aorta. Fig. 1.14. This will deliver blood directly from the aorta to the coronary arteries, bypassing segmental stenosis. The internal mammary artery is anastomosed directly to the left anterior descending artery as a pedicle graft. Once the cardioplegia solution is washed out of the coronary system, the heart resumes beating. Hemostasis is achieved, and the sternum closed with stainless steel wires. Coronary artery bypass surgery can prolong the quantity and quality of life. The success rate is 95% for complete relief of angina, although this falls to 75% at 5 years. Internal mammary artery patency to the left anterior descending artery is 90% at 10 years, but vein graft occlusion occurs in approximately 15% after the first year and 2 to 4% per year thereafter. The average mortality rate of this procedure is 3%. Postoperatively, stroke occurs in 3% and transient atrial fibrillation in 30%. Other complications include bleeding and wound infection.